My name is Mark Ashworth. I'm a cardiovascular RN. I've been working in the field about 24 years now. Today I'm going to talk to you about chronic heart failure and the causes, the prevention, and certain things that we do to actually help strengthen your heart. Just for some stats, chronic heart failure affects about 5.7 million people in the United States every year. It's very expensive. It actually costs about $30.7 billion a year for the medical care and the medications and the special devices that are used. 1 in 9 people in 2009, actually 1 in 9 deaths in 2009 were actually caused by chronic heart failure. Once a patient is diagnosed, about half of those people actually will pass away within the first 5 years. So it's very important that once you are diagnosed, that you actually know how to treat this condition. The first thing is to know is, what is it? Chronic heart failure is actually caused by either what we call systolic or diastolic heart failure. Basically, when we talk about diastolic, we're talking about a heart that is actually, it's not weak. It's just basically might have a thick wall, left ventricle wall. But usually, diastolic heart failure is actually caused by overloaded fluid. You'll see a lot of dialysis patients have that because of kidney failure, basically where they have accumulated too much fluid. Basically, they can't get rid of it. So it ends up backing up into their lungs, causing pulmonary edema, which is actually fluids in the lungs that actually produces a frothy sputum-like. And if not treated, it can actually end up into cardiac arrest. But the main thing on diastolic heart failure is basically you educate and watch your fluid intake. And if you're on dialysis or basically on renal issues, then you actually go to your dialysis visits accordingly. A lot of these, I will say, a lot of dialysis patients, some of them are non-compliant, and you'll see a recurrent heart failure issues with those. Now, a diastolic heart failure, how you actually differentiate between systolic and diastolic is actually the ejection fraction of the heart. The ejection fraction of the heart is basically the amount of blood that's actually excreted from the heart. Normal ejection fraction, it actually goes in percentage-wise, is about 60 to 70%. So a diastolic heart failure is going to be in the norm range of about 60%, 70% ejection fraction. Now, the difference, now when you end up in systolic heart failure, systolic is basically when the ejection fraction is below 40%. And then it gets a little complicated. The treatment for that changes. You do still watch your fluid intake. You need to watch your diet. You need to watch retention of sodium. So you don't need to be eating a lot of canned goods. You need to be eating good diet, instead of eating canned vegetables or canned foods, you need to eat frozen foods. You need to watch the sodium you put in your food, because wherever salt goes, fluid goes. And with systolic heart failure, there's 2 different types of systolic heart failure. Either you have ischemic heart failure, where the coronary arteries are actually have blockage in them, that actually is causing a problem with blood going to the actual muscle, therefore making the muscle weak and basically throwing you into a cardiomyopathy. Now, then you have non-ischemic. Non-ischemic is basically where the coronaries are completely normal, go into the feed the ventricle just fine, but the problem is that years of hypertension or basically genetics has caused the muscle to be weak, and therefore throws you below that 40%. Now, hypertension causes a weakness because you got to think of the heart like a muscle. Okay, basically that's what it is. It's a muscle. When you actually have hypertension, the pressure inside the arteries is actually causing a problem. So basically the heart has to pump harder to get the blood out of the heart into the vascular system. As you work, basically it's just like going to the gym and working your arms out. The more you work a muscle, the bigger they get. Unfortunately, with the heart, you do not want that muscle to get big because the muscle, basically the heart is in between the lungs, does not have room to expand and to retract. So basically, when you do that, you're basically making it just kind of fibrillate right there, just kind of, and basically that causes a problem. You want a good compression, relaxation. Now, once that heart muscle gets out there and gets big, it cannot do that, and so it throws that ejection fraction down below 40%. So, once you get to that point, once you get into the systolic heart failure, that's where the treatment actually changes. You start treating very aggressive with the diuretics. But you have a catch-22 there because you start treating too far with the diuretics, you start causing renal issues because of the dryness you're causing the body to be. And so you can be on diuretics, but over the years, you'll know your renal function going up, 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 and basically sooner or later, after the few years you've been on diuretics and the aggressiveness of the diuretics, you can start causing renal failure, and then you end up in end-stage cardiomyopathy or end-stage chronic heart failure. And that's where you cannot get rid of the fluid fast enough, and it keeps on accumulating, get into your lungs, causes you shortness of breath, and basically eventually the muscle gets so weak that you actually have issues with sudden death issues, which that is basically where the heart actually is working so hard that it starts fibrillating, or it goes into what's called ventricular tachycardia, and actually the patient will, if they do not have special devices in, will actually pass. Now, the recommendations of systolic heart failure is actually start treating the patient aggressively with what they call ACE inhibitors or ARBs medications, which there's several different types. Basically what that does is actually dilates the vessels out and actually decreases the afterload of the heart. And basically what that's doing is basically dilating the arteries out, so as the heart pumps, the blood goes into the arteries a lot easier and basically lets the heart kind of rest. So you started treating quite aggressive with those. The only issues with those is that they can cause renal issues also. As you can tell, the heart's not the only problem with chronic heart failure. It's going to be the kidneys at the end, because you start treating with medications aggressively. It can start causing kidney issues, and then if you don't treat aggressively, then you're going to end up with basically the same element. But you just have to be monitored very closely, lab work, looking at those kidneys, make sure you're not causing the patient to be too dry, and therefore you're not causing more harm to the patient than needed. Now, once the patient gets down below about 40%, they have more of an issue with sudden death issues. And that's where, say the patient has a low ejection fraction, say about 30-20%, they go out in the yard and they start working. They start working that muscle so hard that it cannot catch up. And when that happens, the blood, basically the heart is trying to pump, is trying to get blood down the coronaries, trying to feed that muscle, but it can't get there fast enough. And once that starts happening, the muscle itself will start basically needing blood. And basically, at that point, the patient might have what they call ventricular tachycardia or VFib, and that's where the ventricle itself actually gets very irritable. And ventricular tachycardia or VFib, the patient cannot get the blood out to the system because it's all ventricle beats. And basically, it's a sudden death issue. So to treat that, the recommendations are basically anything a patient with less than a 40% ejection fraction is required to have a defibrillator. Either that's, and basically that's like a pacemaker, and it's got it basically goes up, usually up in the upper left chest, and basically goes into the subclavian. You put either 1, 2, or 3 leads in. And basically the leads will actually go to the right atrium, right ventricle. And the third lead, which has been out probably for about 10 or 15 years, is called a BiV ventricular, BiV AICD, or automatic internal cardiac defibrillator, or a biventricular pacemaker. And what that does is basically, when you end up putting a third lead in there, a lot of people know what a pacemaker already is. A defibrillator basically is a pacemaker, but it has a way of actually defibrillating the heart internally. You know, we all saw ER where they put the pads on the patient and shock. Well, this is internal, and actually that's what that does. Now, the biventricular AICD basically is basically a third lead goes into the coronary sinus, which is actually the venous return of the heart. And what it does is basically it's recoordinating or resynchronizing the heart and getting the heart back to original beat. And basically doing this basically automated. So you'll have a right ventricle, left ventricle, boom, 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 boom. And therefore, it can end up, there's been some studies shown, basically when you do that biventricular, that it can actually strengthen the heart because you're resynchronizing the heart muscle. And basically, if you know, it's just like timing of your car. If you go out there and you start your car and your timing belt's not right, you're not going to have much power. But if you go out there and you synchronize that timing and everything's beating on like it's supposed to, you're going to have better output. And that's everything you can think of the heart is basically like a plumbing system versus electrical system. So if one of those issues goes wrong, like the plumbing system is going to be the coronary arteries, and the electrical system is basically making the heart beat. So you got to have both those systems right, or you're going to end up with issues one way or another. The best, I mean, after the defibrillator's in and all that, basically the treatment is medications, diuretics, ACE, ARBs, basically to decrease the workload of the heart. And that's what you're trying to do at the end of the day, decrease the workload of the heart. Then the patient cannot be sedentary, cannot be sitting around and just trying to basically, they will just fade away. Okay, so they need to be active, exercise as much as possible. And the main thing about a new diagnosed chronic heart failure patient, you need to teach diet control. Always teach diet control. Reduce the sodium, reduce the water, and basically eat a healthy diet. Don't go out there and eat 10 bags of potato chips or anything like that, because it's going to cause retention of sodium. You have to just do a lot of diet teaching, okay? And just watch the sodium. Where sodium goes, the water goes. Now, the main risk factors for patients developing these kinds of disease is basically coronary artery disease, hypertension, diabetes, smoking, obesity, and sedentary lifestyle. Few of those are actually stuff we can actually change. You know, you can change obesity, you can change the sedentary lifestyle, you can affect, by exercising, you can actually decrease your chance of having hypertension. And one thing we can't really mess with too much is coronary artery disease. I mean, to some degree you can, because the diet actually has a lot to do with that, and your sedentary lifestyle has a lot to do with that also. But sometimes genetics actually plays a role, and also genetics plays a role in diabetes, but also obesity and exercise does too. As you can tell, we are our own advocate. Basically, if you attempt to live and exercise, watch your diet, and actually go to the doctor on a frequent basis. Make sure you don't, if you have hypertension, get it treated. Because it's going to end up catching you at the end. It's going to weaken your heart muscle. It's going to cause you to have coronary artery disease. It's going to cause you to have a lot of issues. So always treat. Okay? Don't just think you don't need treatment because you don't have a headache, you don't have any problems or anything like that. It will catch up with you. Okay. If you have any questions or anything, just send me a reply. And thank you for listening.